oral cavities are plaque, gingivitis, periodontitis, dental caries, as well as halitosis. And the risk factors, as we all know, nothing new to say to all this learned audience over here. The risk factors like smoking, poor oral hygiene, or even medications, and fast food, especially sugars, which leads to different oral conditions, pathogenic conditions. Even diabetes and pregnancy also increases the chances. Some of the very common oral pathogens what we have in our oral cavity, which causes disease conditions like A. viscosa, Streptococcus mutans, Pivotella intermedia, or Porphyromonas gingivalis, commonly known as P. gingivalis. This causes different conditions, like the plaques and the caries are being caused by A. viscosas and S. mutans, while periodontal conditions are being caused by mainly P. gingivalis and P. intermedia. However, the signs and symptoms are well known to all of you, I believe, because you are all, most of your students and all the dignitaries and the professors who are here. I will not go into details of it. However, the limitations of the current therapy, what mostly has been managed with, is antibiotics. But definitely antibiotics have its own limitations, because it's non-specific action. It kills both good as well as the bad or the pathogenic bacteria. There is chances of development of resistance, short-term effects, and recurrence are also there. And it has some side effects. All antibiotics have one or the other side effects. To address this, we have now a probiotic solution. And the probiotics are live microorganisms. As we know, when they've been given in right adequate quantity, it will have some beneficial role in our body. However, till date, there were probiotics for the guts, there were probiotics for kidney health, even for genitalial health we have probiotics, or even for respiratory health also we have some probiotics now in the country. However, for dental health, till date there were no probiotics available in the market. And to address this gap, as JB Pharma, we have introduced a probiotic. But before going into probiotic, I just take 1 minute of yours. That probiotics are the life microorganisms, as you all know, which will have some beneficial role in our body. However, there are prebiotics, which are basically nothing else than the food for the probiotics. Simple sugar and form they will have. And there is a new term which has come up. It is called the heat-killed probiotics. It's a preparation of the inanimates or the non-living microorganisms that confers a health benefit to the host. To put it in a very simple term, only the active part of the cell which is required for giving the beneficial effect, that is been kept. The other part of the cell body of that probiotic is been killed with a particular technology, and this technology is called the heat-kill technology. The advantage of this heat-kill technology or the heat-kill probiotics are, there is no live bacteria in the microbiota that is required. It is stable at any room temperature or any condition. It does not require a freezing or anything which are there for the commonly with any probiotic, that it has to be maintained a certain temperature. Nothing of that sort. Nothing of pH balance to be maintained, as these are not non-living microorganisms. And there is no infections, chances of antimicrobial resistance also. And it is a targeted bioactive effect will be there on the target organs only. That's the very specific way of working of it. That's the main advantage of this heat-killed probiotics. And the probiotic, what we have using in our new introduction, it is called Lactobacillus paracasi GMNL 33. the strain is very particular, GMNL33. It's a facultative anaerobic bacteria, lactic acid producing gram-positive bacteria having some beneficial roles in our body. And the parts which are very beneficial to our oral cavity are the lipoic acid and the peptidoglycans which are present in the cell wall of this probiotic. That is only there in the brand what we are having, which is called Sporlac DG. It's a very new concept of probiotic what we are introducing, which is called a heat-killed probiotic only for the oral cavity. Doctors, the mechanism action of this probiotic is its anti-pathogenic activity because it has a co-aggregates with the pathogens, inhibits the addition and facilitates the removal of the pathogens. It inhibits the growth of pathogens also, and it has an immunomodulatory activity because it increases it has been found in different trials that it inhibits the salivary IgA also. Why we have chosen this particular strain? Because we have been finding that this particular strain of Lactobacillus paracasi GMNL33, this is very effective not only in reducing the counts of bacteria, but also significantly it increases the pH level of the mouth. It also increases the salivary IgA level, which no other probiotics offer to your patient. Some of the clinical highlights, just to take some of your moments. In a 2-week period of medication versus oral administration route, it's found that the Lactobacillus paracasi GMNL33 is effective in probiotic actions, not only when it has been given, but even after withdrawing the treatment, after withdrawing the administration, till for 2 weeks, the bacterial count was, pathogenic count was much less. Even in the second clinical trial, what we have found that when it has been given, it showed a reduction in the number of patients with positive periodontal pathogens as compared to when the start of the treatment. Even after withdrawal of the treatment, 2 weeks after the withdrawal of the treatment, still the pathogen count was less. And even the periodontal probing depth has improved by 60% in these patients that has been found. If anyone wants the further of these details of these studies, we can definitely provide you, doctors, the entire studies. And the key highlights of this Sporlac DG, what we call, it's a clinically studied heat-killed probiotic strain of Lactobacillus paracasi GMNL33. It maintains the oral and the dental health. It carries inhibits the caries-causing bacteria and periodontal pathogens, reduces the dental plaque formations and gingival inflammation. And it's very long-lasting. And if I go into the summary of it, just to conclude, that Lactobacillus paracasi GMNL33, a heat-killed probiotic that we are using in Sporlac DG, it emerges as a promising option for dentistry, especially as an adjunct to the standard care for the treatment of periodontitis, gingivitis, or even dental caries, as it inhibits the caries and periodontal pathogens, reduces dental plaque formations, reduces gingival inflammation. It also enhances immune responses. So doctor, looking forward for your using of this brand for your trial in this institute with request. That's all from JB Pharma. That's all from my side. Thank you for your patience hearing. If any queries, I'll be very glad to give you replies on that. Otherwise, thank you. Thank you for the entire session. Thank you for the patience hearing.
Sir Malcolm X once said, I quote, "Education is the passport to the future for tomorrow, belongs to the people who prepare for it." I unquote. As the saying goes by Sir William Butler, I quote, "Education is not the filling of a pail, but the lighting of a fire." I unquote. A very good morning, ladies and gentlemen. I extend a warm welcome to all those who have gathered here today to be enriched by the wisdom and knowledge from the most esteemed personalities who have won accolades in their respective medical specialties. Finally, the much awaited day arrives. On behalf of Guru Nanak Institute of Dental Sciences and Research, JIS Group, I, Dr. Divya Pandya, Associate Professor, Department of Oral Medicine and Radiology, would like to express my sincere gratitude and welcome you all to the second edition of the International Dental Conference SPEAK, Scientific Platform for Exchange of Advanced Knowledge 2025, along with commemoration of National Oral Medicine and Radiology Day 2025, organized by Departments of Oral Medicine and Radiology, Oral and Maxillofacial Pathology and Periodontology, collaboration with GNIDSR Alumni Association, Kolkata, West Bengal. I honorably welcome our eminent speakers, respected dignitaries, respected heads and faculties of all departments, postgraduate trainees and dear students. I would like to extend my gratitude towards our Principal Sir, Professor Dr. Jayanto Bhattacharya, our Superintendent Sir, Professor Dr. Shoumitra Ghosh Sir, Professor Dr. Kaushik Datta Sir, Head Department of OMR, for taking this initiative and guiding us. Professor Dr. Maushmi Pal Ma'am, Head Department of Oral Pathology and Microbiology, and Professor Dr. Abhijit Chakravarti Sir, Head Department of Periodontology, for their unwavering support and motivation for this program. And special mention to the entire team of Oricam for making this event a success. So ladies and gentlemen, with a huge round of applause, let's begin with the scientific brainstorming. Now, let's welcome on stage the chairperson for our first lecture with a big round of applause, Dr. Maushmi Pal Ma'am. Ma'am is professor and head in the Department of Oral Pathology and Microbiology in Guru Nanak Institute of Dental Sciences and Research. Ma'am completed her PhD in 2019, the first one in oral and dental sciences from West Bengal University of Health Sciences, Kolkata. Ma'am is a co-investigator and has completed research projects with SMST IIT Kharagpur, submitted to West Bengal DST in 2018, and ECE IIT Kharagpur, submitted to SERB Government of India in 2021, an ongoing project with SMST IIT Kharagpur, submitted to ICMR. Ma'am has more than 100 publications in national and international journals, and the most prestigious publication is in the Proceedings of the National Academy of Sciences of the United States of America in 2022, along with IIT Kharagpur, which is being patented in March 2020. Ma'am focus area includes oral pre-cancer and cancer lesions. And now I would request ma'am to kindly introduce the first speaker for today's program, Dr. Pramod John, sir.
Thank you, Divya, for your generous introduction. Now I would like to invite Professor Dr. Pramod John, who is Professor in Oral Medicine and Radiology and Director of Research, GNIDSR, Kolkata. Sir completed his BSc degree from Sacred Heart College and BDS and MDS from KMC Manipal. He served in the same institute as lecturer till professor. Sir also served as professor and head of the department at Mahatma Gandhi Government Dental College, Pondicherry, and Amrita School of Dentistry, Cochin. Sir has 34 years of UG and PG teaching experience and has received Best Teacher Award 3 times. Sir is actively involved in student counseling, value-based education, and student mentorship program. He has numerous publications in national and international journals. Sir was the editor of Journal of IDA and underwent leadership training in Singapore. He was a board member in the Department of Oncology in Amrita Institute of Medical Sciences. He has authored textbooks in OMR and was invited speaker in various national and international conferences. Sir is a member of Southeast Asian Association for Dental Education and obtained UICC fellowship to work as observer, first observer, Oncology Department of University of Suffolk, UK. His research paper on tumor markers was accepted in annual meeting of International Association of Dental Research, Sweden, 2002, and research paper on modern diagnostic modalities in detection of maxillofacial malignancies in Annual International Association of Maxillofacial Surgeons, Cyprus, in 2018. Sir was a keynote speaker in World Dental Conference in Kuala Lumpur in 2019. With this, I invite Professor Dr. Pramod John to deliver his lecture. So please.
Big round of applause, ladies and gentlemen.
Good morning, everybody. Thanks, Dr. Moshmi Pal, for the generous introduction. So today, the topic that I am going to talk on is diagnosing and taming hypersensitivity of teeth. As you know, dental pain is worse than labor pain. So there is a general saying. So the pain can be due to hypersensitivity of teeth, which is also known as dentinal hypersensitivity, or it can be due to pulp hyperemia, it can be due to pulpitis, acute or chronic. So there are a lot of causes for, or aerodontalgia. There are so many causes for pain. So I think some of you might have felt hypersensitivity at some point of time. Or you might have come across a lot of patients suffering from hypersensitivity. I became interested in hypersensitivity when I was working in Amrita School of Dentistry. It is part of Amrita Vishwa Vidyapeeth deemed university. So I did a lot of studies on hypersensitivity during my tenure in Amrita School of Dentistry. And the major content of the presentation was one lecture which I delivered in a CD program when I was working in Amrita in 2013. That is almost 12 years back. So I still hold the wonderful memories of my Amrita days. Amrita happens to be close to my house. It is just walking distance. So I have a lot of fond memories about Amrita School of Dentistry. So I wanted to remember my previous institution. So that is why the first slide is my designation in Amrita. So this is the typical facial expression when you have hypersensitivity. I think some of you might have witnessed, some of your family members might have had hypersensitivity. So what happens if you have hypersensitivity? You cannot enjoy ice cream? Yes or no? How many of you have suffered hypersensitivity or dentinal hypersensitivity? Can you lift your hands? One person, two, 3, 4, 5, 6, or so many people have suffered hypersensitivity. So you may be knowing what are the etiological factors of hypersensitivity and how to manage. I am just giving you some guidelines in the management from the experience that I have gained in managing hypersensitivity. So he is trying to eat an ice cream, but because of hypersensitivity, he cannot enjoy the ice cream. So the definition of hypersensitivity, I am fond of definitions. So the definition says that hypersensitivity of teeth is characterized by short, sharp pain arising from exposed dentine in response to stimuli, typically thermal, evaporative, tactile, osmotic, or chemical, that cannot be ascribed to any other dental defect or disease. This was proposed by Canadian Advisory Board on dentine hypersensitivity. So this is the standard and accepted definition for hypersensitivity of teeth. A short definition is tooth sensitivity, also known as dentine hypersensitivity, is a sharp, short-lived pain in the teeth that occurs in response to stimuli like hot, cold, or sweet foods and drinks. I think you can see, or is it small? The font size is small. Should I increase the size? Is it fine? Okay. Now, statistically, the prevalence is about 4 to 57%, and it is more common in patients with the periodontitis. So it is about 60 to 98% if the patient is also having periodontitis. Majority of patients do not seek treatment. Treatment is sought only by 1% of diagnosed cases. That's the tragic part. So how others manage, I don't know. Or maybe after some time it settles. There is always the tertiary dentine formation close to the pulp, and patients get relief from hypersensitivity. More prevalent in the age group between 30 and 40 years of age. It can affect any age group. There is no specific age group in which hypersensitivity occurs. It can occur in any age group. And it is more common in women. I assume it could be because they tend to clench teeth. Men have a lot of relaxing mechanisms, whereas if they become angry, they tend to clench teeth. Probably that could be the reason. Affects any tooth, but commonly canines and premolars are affected. So you can see a small defect in the enamel can cause hypersensitivity when the dentine is exposed. So you know the structure of the teeth, and the dentine is exposed clinically, so it can result in hypersensitivity. Now, what are the causes of hypersensitivity? Thinning of enamel, So some people vigorously brush their teeth, especially using hard toothbrush. So that can cause the wearing away of the enamel. So gingival recession causing exposure of such gingival cementum, grinding of teeth leading to enamel wear and exposure of dentine. So these are there are other causes as also. Habitual ingestion of acidic substances like lemon. I had a patient of mine, he was gynecology PG in Manipal. So he came to me and he said he is having hypersensitivity of teeth. And when I checked his mouth, he had a lot of cervical aberrations. And once he invited me to his room, I found that he has kilos of grapes and oranges in his room. So that was the cause. He was eating a lot of grapes and oranges. So that had caused him, made him a victim of cervical aberrations. And he underwent endophoresis for the hypersensitivity and it helped him. So use of tobacco for chewing. Patients with bulimia and gastroesophageal reflux disease, they habitually induce vomiting. So because of the gastric acid, it can cause erosion of enamel. Periodontal disease, after oral prophylaxis, there can be transient hypersensitivity. Many people complain that once they undergo scaling or root planing, the patients experience hypersensitivity. That is very transient, so it gets resolved over a period of time. After restoration, sometimes when you place a restoration for 2 days, patient can get hypersensitivity, which is considered normal. Only it becomes a matter of concern if the pain persists for more than 2 days. Other causes are tooth fracture, which is one of the commonest causes, internal resorption, cracked tooth, or trauma. So how erosion looks, typically the cervical area is affected, but in case of induced vomiting, the inner surface, the lingual or palatal surfaces may be affected because of the chemical erosion. So you can see the erosion due to gastric acid. The lingual surface of the enamel is affected. Overzealous tooth brushing can cause cervical aberration that usually occurs in the cervical region. So attrition, fracture of teeth. So here the fracture is clinically visible, but there can also be clinically invisible fracture lines. So that is one of the things that you need to consider if the patient is not responding to any other treatment. Enamel wear, internal resorption. Internal resorption can also sometimes cause hypersensitivity of teeth. Here you can see a cracked tooth. This is clinically visible, but sometimes there can also be clinically invisible fractures which could be a cause for hypersensitivity. You can see the multiple cracks on the tooth surface which can cause pulp hypersensitivity of the teeth. So you can see the cracked tooth after it was extracted. So there are different cemento-enamel junctions which you might have studied in the dental anatomy. Commonly, cementum is over enamel. Enamel and cementum in edge-to-edge relationship, presence of gap between enamel and cementum with the dentine exposure, which is one of the causes for hypersensitivity. There can also be combinations. So this you might have already studied about the various junctions. So this is the diagrammatic representation. So just a review about dentine. It is a specialized connective tissue that makes up the bulk of the tooth. As you know, the tooth is made predominantly of dentine. Dentine is hard, elastic, and is 70% mineralized. Unlike enamel, which is acellular, dentine has cellular component. There is a cytoplasmic extension in the which are known as odontoblasts. So once the odontoblasts are exposed, the tooth can experience hypersensitivity. A characteristic of dentine is it is permeated by closely packed tubules traversing its thickness and which contain cytoplasmic extensions that form dentine and maintain the dentine. So when pulp of the tooth dies or is removed by the dentist, the dentine becomes brittle and is liable to fracture. So that is why we advise crown after root canal treatment. The color of dentine is yellowish white. The hardness of dentine is less than that of enamel but is greater than that of cementum. Like enamel, it is semi-permeable to certain ions. That is why the teeth become discolored once it becomes non-vital. So each odontoblast gives rise to a cytoplasmic extension traversing the thickness of the dentine. The odontoblastic processes occupy the dentinal tubules. So that is why once the dentine is clinically exposed, patient develops dentinal hypersensitivity. These processes were earlier known as Tom's fibers. So there is one per odontoblast. In older persons, the dentinal tubules silt up with mineralized substances. In a section, the dentine appears transparent and is called sclerotic dentine. So sclerotic dentine is transparent and visible when you do a section, ground section. This is the diagrammatic representation of how the dentine is forming. This is the odontoblast. You can see the cytoplasmic extensions going towards the dentino-enamel junction. There is a dentinal tubule. So mechanism of hypersensitivity. There are various theories, but the mostly accepted theory is hydrodynamic theory. So dentine is sensitive due to proximity with pulp. In hypersensitivity, dentinal tubules are more numerous and wider. Hypersensitivity may be mediated by a hydrodynamic mechanism. So pain-provoking stimulus, mainly the cold stimulus, increases the flow of dentinal tubular fluid. It activates nerves in the inner end of tubules and outer layers of pulp. Anybody can tell me the reason why you feel pain when you take something sweet, but when you take something salty, it is not giving hypersensitivity. What could be the reason? Anybody can give me the answer? Anybody? Third year students, final year students? What could be the reason? Salt will not cause hypersensitivity, but sugar can cause. Anyway, you can find out. If anybody was willing to give an answer, I could have helped in finding out the answer, but nobody is willing to. So I found this answer only in one journal. And that is actually based on several studies. They have found that there is a specific reason why sugar is causing hypersensitivity. Anyway, so this is what happens. There is increased tubular flow, which could be one of the reasons why hypersensitivity occurs. Here you can see the flow chart, how hypersensitivity is induced. So there are some stages in hypersensitivity. Lesion localization. So first, an area is identified where hypersensitivity is the starting point. Initiated by either loss of enamel or gingival recession, not all exposed dentin is sensitive. Smear layer of tubular plugs must be removed for hypersensitivity to occur. It is something like when you apply cement over the breaks, so it covers the defects. So smear layer basically covers the defects on the tooth surface, which prevents hypersensitivity. So when the smear layer is removed, then hypersensitivity sets in. Abrasion and erosion contribute in hypersensitivity. Acid erosion is more serious. So also it is contributed by periodontitis. Plaque is not a significant factor in the etiology of hypersensitivity. Attrition causes less hypersensitivity due to tertiary dentine deposition, because tertiary dentine is deposited in the pulpal wall of the dentine, so it prevents hypersensitivity. So that is why patients who have severe attrition may not be having any sensitivity. Tertiary dentine, it occurs in response to various external stimuli such as dental caries, attrition and trauma. Tertiary dentine is synthesized. If the injury is severe, it causes odontoblast cell death. Odontoblast like cells synthesize specific reparative dentin just beneath the site of injury to protect the pulp tissue. So it is basically a protective mechanism. So you can see the tertiary dentine formation close to the pulpal wall. So there is transient hypersensitivity, which I already told about. This happens when the patient undergoes oral prophylaxis or root planning. So it is transient. It responds. It usually regresses after 2-3 days. Now, how do you diagnose hypersensitivity? You need to take a proper history. You need to examine. Diagnostic tests must be performed. Then you come to a diagnosis. Exclude other causes for transient pain. Use pain scores. You can use the VAS, visual analog scale, to identify the intensity of hypersensitivity. Use of probe, jet of air, heat and cold, etc., in order to identify the severity of hypersensitivity. Now, how do you manage? So eliminate predisposing etiological factors such as endogenous and exogenous acids or toothbrush trauma. So if the patient is using a hard toothbrush, you should tell the patient to use a medium toothbrush or a soft toothbrush. So you need to remove the predisposing factors. So that is the initial step in the management. Exogenous acid sources must be reduced, especially the citrus fruits. Fruit juices, wine, etc. can remove the smear layer of dentine and expose dentinal tubules. Endogenous acids, gastric acid reflux or regurgitation should be prevented. Toothbrushing with abrasives and faulty technique can open up dentinal tubules. Another important thing is avoid brushing 2 to 3 hours after consuming any acidic beverages, because that can cause dissolution of enamel. So avoid brushing the teeth after consuming acidic beverages, especially the fruit juices or synthetic drinks. There are basically two methods in managing dentinal hypersensitivity. One is called as self-administered by the patient, or at home practices applied by or at office or in office methods, which is usually done by a professional, dental professional on the patient. So one is self-care and the other one is professional care. So the objectives in the management you can see in the flow chart. So basically, to avoid a pain producing stimulus, to occlude the dentinal tubules, formation of smear layer. So what we are doing is we are trying to produce or induce a smear layer which prevents hypersensitivity. Now let us see at-home management. So there are various dentifrices containing various chemical substances that are used to reduce hypersensitivity. So commonly used ones are either they occlude dentinal tubules such as strontium chloride and fluorides. They induce a smear layer formation, so it prevents hypersensitivity. Some destroy the vital elements such as formaldehyde. For example, hemoform. Hemoform basically it destroys the vital elements of the dentinal tubules so that hypersensitivity is prevented. Nowadays, most of the desensitizing toothpaste contain potassium salts such as potassium nitrate, potassium chloride or potassium citrate. Then remineralizing toothpaste containing sodium fluoride and calcium phosphates are also popular. So potassium salts, how do they act? They diffuse along the dentinal tubules and decrease the excitability of intradental nerves by altering their membrane potential. So that is how potassium salts act. And I have found that potassium containing dentifrices are the best agents in reducing hypersensitivity. Some of the results: paste containing 5% potassium nitrate and 3.75% potassium chloride were found to be very effective. Products containing 5% potassium nitrate and 0.454% stannous fluoride in a silica base was found to be very effective. Products containing 5% potassium nitrate and 0.243% sodium fluoride in silica base was not very effective, same as that of 5% potassium nitrate and 0.76% sodium monofluorophosphate in a dicalcium phosphate base. So there are various preparations available. Pro-argin technology, it is quite expensive. So many patients, even if we prescribe this, they don't buy it as these pastes are very expensive. So Sensodyne, it is there in all commercial advertisements. You find about the Sensodyne promotion. But I haven't found Sensodyne to be very effective in reducing hypersensitivity. So comparison of Colgate Pro Relief and Sensodyne. So a study was carried out and they found that the Colgate Sensitive Pro Relief toothpaste provide a significantly more reduction in dentin hypersensitivity than Sensodyne Rapid Relief and Crest Fluoride toothpaste. There are various agents available. I personally prefer Sensodyne K. So I usually prescribe Sensodyne K. So other toothpaste, I haven't found them to be quite useful in reducing hypersensitivity. Now, how do you apply? So many people advise the toothpaste should be applied with finger. Actually, it is not so. The patient should be asked to squeeze 1 inch of the paste onto the brush. Patient should brush the teeth and leave it for 10 minutes and only then should rinse the mouth. So should be applied with a toothpaste, not with the finger. Application with finger is not effective. Immediate rinsing must be avoided. Patient should keep it for 10 minutes, only then the patient should rinse the mouth. There are various mouthwashes, but they are quite expensive. Mouthwashes contain potassium nitrate and sodium fluoride, or potassium citrate and sodium fluoride. And there are also chewing gums containing potassium chloride. These are some of the mouthwashes. The single AD, the third one, is quite effective in managing hypersensitivity. Sensodyne mouthwash is quite expensive. Same with Bandage. So even if you prescribe these, to patients, they may not buy it. Whereas Senguel AD is less expensive. It is costing around 300 rupees. So it is quite effective in managing hypersensitivity. Chewing gums. Chewing sugar-free gum, especially those containing xylitol, can help in reducing the sensitivity, maybe because it induces salivation. So salivation can help in remineralization of the enamel defects. In-office management. So these are carried out in the office, in the dental office. So earlier toxic chemicals such as silver nitrate, zinc chloride, potash and arsenic compounds were used to block the dentinal tubules. So there are various agents such as fluorides, sodium fluoride and stannous fluoride reduce sensitivity by decreasing the permeability of dentine. Potassium nitrate applied as aqueous solution or gel. Potassium oxalate, it reduces the dentine permeability and occludes the dentinal tubules. Calcium phosphates occlude dentinal tubules and decrease dentine permeability. Then adhesives and resins. So most of the topical desensitizing agents do not adhere and effects are temporary. So adhesives, varnishes, bonding agents and restorative materials act as impregnation agents. So there are certain other procedures. I am an advocate of iontophoresis. I routinely use iontophoresis for the patients. When I was in Amrita, I had a iontophoresis unit. So especially in patients who experience hypersensitivity after oral prophylaxis. So I use iontophoresis for these patients. So there is an applicator tray. One electrode is connected to the applicator tray. So it will have a sponge which is loaded with APF gel. The patient, it is kept in the patient's mouth, and to complete the circuit, the patient will be holding the other end of the electrode. And an electric current is used to drive in the active pharmacological agent into the dentinal tubules so that the patient gets relief from hypersensitivity. There are various equipments available. So one of my students, her name is Kirti, she has done a study on iontophoresis, the comparison of iontophoresis and desensitizing paste, and she has found that iontophoresis is very effective in reducing hypersensitivity. So you can find this article in the site that I have given, and she got the best paper award, and her studies were internationally popular. So her paper was titled "A Comparison of the Efficacy of Iontophoresis and Desensitizing Toothpaste in the Management of Dentinal Hypersensitivity, a Clinical Study." So the study compared the two different treatment modalities for dentinal hypersensitivity, one through iontophoresis and the other using desensitizing toothpaste. So she has done the study in my department, and she found that the iontophoresis was much better in reducing hypersensitivity. Lasers found to be 5 to 100% effective. So lasers are not routinely used though. Miscellaneous methods, periodontal surgeries, occlusal adjustments, these can be carried out. So conclusion, be aware of causative factors for dentinal hypersensitivity. Identify these factors and prevent them. For effectiveness of treatment, at home and at office methods must be optimally combined. Effectiveness can vary from patient to patient. So one treatment method may not be effective in all the patients. That is one thing which you need to understand. And in case the patient is not responding to any of the treatment modalities, you have to suspect a cracked tooth syndrome. For localized cases confined to one or few teeth, in-office methods are better. Suppose the patient is having generalized hypersensitivity, then you can advise toothpaste for or desensitizing toothpaste. So once you effectively manage, a painful person can be transformed to a smiling person. So hypersensitivity from pain, you can transform it to a smiling face. So thank you for your patient listening. I have been given only 45 minutes. I think I didn't exceed the time. So if you have any questions, I can answer.
Thank you very much for your insights into the most common so I just want to ask you the comparison that you made regarding the toothpaste. Was your personal experience or it is published? Means it is
Not my personal experience. I don't have hypersensitivity. It was
no,
actually
personal experience regarding the management, sir.
yes.
Okay.
You are talking about the particular study.
No, not the study. Various desensitizing paste that you have shown, and
Yes.
you have said that Sensodyne
It is based on my clinical experience in
Okay,
managing hypersensitivity of the patients reporting to the department.
Okay. Thank you, sir.
And iontophoresis, it has to be done for a period of 15 minutes to 40 minutes in each session. It has to be repeated. Depending on some patients get relief even in the first attempt. I think you must be having iontophoresis unit in the department, periodontics. I think it is mandatory. The Dental Council of India says that you need to have iontophoresis. Any perio persons in the audience?
Perio head dip is there, so he iontophoresis unit in your department. It's not there, sir.
It is not there. I think you can ask for it. It is not very expensive, but it is quite useful in managing hypersensitivity. And it's a Dental Council of India requirement. I had it in my department because earlier regulations used to say that oral medicine department should have iontophoresis. You can do a lot of studies with iontophoresis unit. It can also be used in periodontics for delivering LA, painless delivery of local anesthesia. So it has a lot of uses actually. Yeah. I can help you with the deal.
That's okay. Thank you so much, sir, for enlightening us on such an important topic. Now, thank you so much, Moshi ma'am, for chairpersoning this session. Now, I would request Professor Dr. Moshmi Pal ma'am to kindly felicitate Dr. Pramod John sir with an Uttorio and memento. Big round of applause, ladies and gentlemen. Now, I would request Dr. Abhijit Chakravarti sir Professor and Head, Department of Periodontology, to kindly felicitate Professor Dr. Moshmi Pal ma'am with a Turio and memento. A big round of applause, ladies and gentlemen. Thank you so much, sir. Thank you so much, ma'am. On behalf of Guru Nanak Institute of Dental Sciences and Research, GIS Group, we extend a warm welcome to Dr. Nami Savi Juneja. A big round of applause, ladies and gentlemen. Dr. Juneja has come down from Mumbai, and I would request Professor Dr. Jayantu Bhattacharya, sir, Principal JNIDSR, to kindly come up on stage, sir, and please felicitate Dr. Juneja. Dr. Juneja, please come up on the stage. A big round of applause, ladies and gentlemen, and Dr. Juneja, welcome to Kolkata. Don't stop clapping, audience. Now, I would request Professor Dr. Prashantit Banerjee, sir, Professor in the Department of Orthodontics, to kindly felicitate Professor Dr. Himadri, sir, Himadri Chakrabarti, sir. Big round of applause, ladies and gentlemen. Thank you so much, sir. As Sir Alan Bloom once said, and I quote, "Education is the movement from darkness to light," I unquote. As Sir Michael Jordan once said, "Focus like a laser, not a flashlight." Sir Bruce Lee also once said, I quote, "The successful warrior is the average man with laser-like focus," I unquote. Now it's the time for the second lecture for today's course and the highlights. So I request the chairperson for our second lecture, Dr. Himadri Chakrabarti, sir, Professor in the Department of Periodontology, to kindly come up on stage, please. Sir is Professor in Periodontics, JNIDSR. Sir has finished his Masters in Periodontics in 2003 from Dr. R. Ahmed Dental College and Hospital. Sir has lectured all over India on dental implantology with a clinical experience in placing over 1,000 implants of different systems with a plethora of diversities. Sir has presented an international position paper in second International Anthology Leaders Meeting in Antalya, Turkey in 2010. Sir completed his MSc program from University of Genoa, Italy in laser dentistry in 2014. Sir has been awarded Clinical Mastership Certificate from Stony Brook School of Dental Medicine, United States of America, and Dental XP Externship Certificate Program in Implantology and Implants Prosthodontics Master Program from Anacapa Dental Art Institute, California, United States of America. We welcome you, sir. Now I would request sir to kindly introduce our eminent guest speaker for today, Dr. Juneja. A big round of applause for sir and ma'am.
Thank you very much, Divya. It's my pleasure today to introduce Nami because she's so junior to me and we are in the same fraternity. Dr. Nami Juneja did her bachelor's from D.Y. Patil School of Dentistry in Navi Mumbai in the year of 2014, followed by complete training from Maharashtra University of Health and Sciences in laser dentistry and associate fellow for laser dentistry from WCLI with management of sleep apnea USA. She's practicing dentistry since 11 years with private practice, keen interest in laser dentistry, implants and cosmetic dentistry. She's official smile expert from Miss Navi Mumbai since 2022 and dentist for many celebrities. She is the KOL for Sogal Laser and Noricum Healthcare. She conducts various hands-on core laser courses across the country. She is laser specialist for both hard and soft tissue, and she has won the Dental Clinician of the Year Awards in 2020 by Indian Professional Awards and nominated in Famdent Awards for Budding Dentist in the year 2022. And she has won Smile Architect Award in 2023 in Women's Day Special Awards in Navi Mumbai. May I have the pleasure to call Dr. Nami Savi Juneja for this lecture, please. Thank you very much for coming in Calcutta. Welcome onto the stage.
A big round of applause, everyone. Welcome, Dr. Juneja, to the dais and to Kolkata. Stage is all yours.
Thank you so much, and thank you so much for such a lovely introduction. I wouldn't have had it the any other way as sir has introduced me to. Okay, so, so am I audible to you? Guru Nanak Dental College? All right. So I'm not a person who will just speak one-sided. I want your attention and your participation as well as when I am speaking. Okay? So, as you see, this is my presentation, Major Laser Dentistry by Dr. Nami. That's my presentation name. So I also take courses named Major Laser Dentistry by Dr. Nami. So it's a 2-day course in Mumbai. And today I'm in the city of joy of Kolkata. Okay? So as you see, puchka has various flavors of sweet, tangy and everything all in between. My presentation will also be similar to that of puchka. Okay? So this is the flyers. Okay, sir's already introduced me. So this is from one of my presentations in Mumbai. So it's a 2-day course. I'm a laser specialist practicing the last 4 years and the laser dentistry, fellow of laser dentistry. I came second in Maharashtra University and also associate fellow of laser dentistry WCLI USA. 11 years of clinical practice along with being the smile expert for Miss Navi Mumbai pageant and also trained for sleep apnea with Dr. Darren Ramsey, DDS USA. And also, I'm an implantologist, which I haven't written in the resume. Practiced implant dentistry from the last 2-3 years now, and awarded Clinician of the Year in the year 2020. Okay, so with lasers, It's a technology which is very new. Everybody is very keen to know about laser dentistry in general. So what I begin with a nice quote, which already ma'am has already told you all, but I would also like to add my own quote. Any sufficiently advanced technology is indistinguishable from magic. So laser dentistry is indistinguishable from magic because lasers is itself magic. Now what does this magic is all about is I'll be going through the presentation throughout. So I will need all of your attention in this magic because I can't create magic alone. I need your help as well to create magic. The magic. So laser dentistry, laser, the complete full form of lasers is light amplification by stimulated emission of radiation. So it's like the terms might feel very overwhelming, that what exactly light amplification, stimulated emission of radiation is exactly. So as of now, I'll not be covering a lot of physics because I have only 1.5 hour of time max limit. So I'll be covering very less aspects of physics, but I can only say that stimulated emission of radiation is based on the model of Niels Bohr's atomic model of the stimulated emission of radiation, and there is spontaneous emission of radiation. So I will not be going in depth of physics, and I'll be focusing more so on the clinical aspect as well, and more so how y'all can practice as clinicians in the future. So before going on to the main presentation, I would like to just introduce y'all to Orikim's laser. We have two lasers. We have one that of tabletop model and one of that of pen type model. So pen type model is a more user-friendly aspect. It's more so for a beginner who has never practiced laser dentistry, and it's of single wavelength 980, whereas tabletop model is triple wavelength. We have 980, we have 960, and we have 450. We have 3 wavelengths in the tabletop model. So this is just a small introduction of the laser models. 2 of them are there with Soga Orikim, and they are very pocket friendly as well, because triple wavelength, that's the only wavelength in the market which is under 3 lakh rupees, and the pen type model is under 2 lakh rupees. So otherwise lasers of this wavelength are very costly in general. So this is a small marketing introduction. So before we go on to any subject, like we have studied in our college various subjects, what do we study first is the history of the subject. So let me introduce to the history of lasers. Lasers was originally, it was not really introduced by default, it came as an accident. The researchers were discovering if they can cure cancer with laser, but actually it was helping them heal the lesions which caused, for example, oral mucositis. That also that cells were healing with laser. It didn't really cure the cancer as such, because the penetration depth has a limit. That is why we cannot cure cancer as such with laser, but that is how lasers came into place and play. So the theoretical part of the laser dentistry. Dioptry Maimin first invented lasers in 1960. So it's a very new technology comparatively, because 1960 it was first actually invented. And later on, as we go further, it was more advanced. Diode lasers came into place more so. And Leon Goldman in the year 1966, 1966, brought about hard tissue lasers. So hard tissue lasers, and I will come to that difference as well. So it cuts in enamel and dentine as well. The Soga lasers are more so diode lasers, and they are more so soft lasers. They are not hard tissue lasers, but the Orikim team is in the manufacturing of hard tissue lasers. I think by the end of this year, we will have hard tissue lasers, that is yak laser, erbium yak laser, which is also hard tissue. It will cut hard tissue as well. So it's then manufacturing in a year. So in 1967, photobiomodulation was actually discovered. Okay, so in that case, we had shaved mice, and on those shaved mice, we tried to go hair. Like you have hair PRP treatments in general for your hair. So we tried using laser for hair PRP, and that is how photobiomodulation came into place. Means it helps in growing. Something is growing. So that's how research is still being carried out. Every year we have a new article. Every day we have something new to learn about lasers. It's always a very evolving field of technology. Also, NASA scientists, when they go up in the airspace, recently Sunita Williams just came back, right? Everybody has heard that news? I want a bigger yes. That's great. Okay, so when the astronauts go up in the air, in the airspace, in the space area, over there the wound healing is supposed to be extremely slow because naturally everything is gone for a toss. It's nothing like that on Earth. So lasers is also in 1990s. It was helping the astronauts help with the wound recovery up in the space because we can't have the healing mechanisms to be the same as that of Earth. So this is a small brief history about lasers before we go on to the main subjects of lasers. Okay, so why laser dentistry? What's so special? Like 11 a.m. in the morning, I'm here streaming live and all of you are, instead of class, you're attending the lectures. What exactly is so special about lasers? What makes lasers so special? And why is it gaining so much of popularity in the last few years after COVID? Especially after COVID, the laser technology has growing over since the years. What's so special about lasers? Okay, this is what special is about lasers. It's hemostatic. It causes almost a bloodless field for the operator to work. It is painless. It is requiring no anesthesia. Most of the cases, you do not require any LA. You do not require any block. Okay? You have just topical anesthesia on it and you're done. You are just sorted for doing lasers, causing any incisions. You can just use a normal topical LA. There is no need for applying sutures. 99% of the cases, you don't really apply sutures in lasers. 1% where you feel you can, but not all the cases you apply sutures. So the suture is out of the place. Periopacks also after gingival depigmentation you don't have to put if you're doing it with lasers. Then also it helps in having a very predictable result. You know, like when you're incising, when you're ablating with a laser, you know it, that this is how the incision will look like. You know, this is what the healing will look like if you've used the laser the right way, you've used the right wavelength, you've used the right power. If you've done all these things perfectly fine, then definitely you'll have a predictable result. So in y'all are still in college, but I don't know. So, but in clinician aspect, we have to guarantee results. The patients are demanding these days outside of this boundary of college. The patients are quite demanding. So they want to know what the guarantee, the warranty, the results and everything. So the laser helps in cutting. It's a cutting edge technology which helps in providing predictable, instant, painless results. And also because a lot of patients have inhibition of having too much of bleeding and post-operative pain, lasers helps in that as well. So as a clinician, when you go outside, lasers will really help you because right now the pain thresholds, if you must be seeing in college as well, we had wonderful pain thresholds back when we were in college. Now the pain thresholds of the patient is also reducing. So this really helps in having the laser technology, that is. Okay, this is clinician aspect. If you're in third year, final year, PG, the patients are happier. Like normally, what do the patients normally say? You always see this kind of expression on patients, isn't it? Yes or no? Yeah. So, and this is you know, hunting for the patients and actually treating them, isn't it? Relatable much? Yeah. So, and when the laser technology comes into place, so when you advertise yourself as someone who's more upgraded, someone who has more knowledge, when you say I'm a laser dentist, I practice lasers, that obviously increases your bar and the patient trusts you more. And it's like half of the psychological effect is already placed. The trust in you is already placed by the patient. The patient is happy because it's not causing them pain. It's predictable. It is not having any bleeding issues. And of course, when you tell there are no sutures application or any periopack application, the patients are automatically willing to get treatment done from you. You have an edge from your competitors. This, it's like, be it in college or be it outside the college, when you become clinicians, then definitely there will be an edge. Constantly like doing only implants and only root canals that every other dentist is doing these days. But having laser dentistry in your practice will give you an edge over others. So, how can I educate my patients? This is clinical aspect completely. That how do I tell my patients? Even if you end up doing PG in the future and you have to educate your patients, how will you tell your patients that, it's going to be good, it's going to be beneficial for your own purpose? The healing time of the incision performed by a laser versus a blade versus an electrocautery will be obviously much more faster, because the laser beam doesn't penetrate very deep into the tissue. Obviously, the wavelength also has to be taken into consideration, which wavelength you're using, one. There is minimized discomfort to the patient post-op, and the risk of infection is also much more lesser. The infection caused by, maybe when you're using blade, there's a lot of bleeding. So you have to give antibiotics, you have to give painkiller. With lasers, the intake of painkillers and antibiotics is also reduced, much lesser than that of regular painkillers and antibiotics. If you do a laser curettage flapless, like if you do a laser curettage without raising the flap versus if you do laser curettage while you open the flap, is very different. So yes, the infection rate goes down, and using laser, it is an antimicrobial light. Lasers is not just for incising the tissues, it's also a antimicrobial light. It helps in sanitizing that area. It is a self-sanitizing light itself. It is antimicrobial sanitizing light itself. So it will help in reduction of the infection. And it has obviously coagulation properties, so that also. And in patients who are compromised medically, for them as well, it's a good technology, because normally if we see, we have to, see if you're diabetic, the patient is diabetic, the patient is having hypertension, the patient is on Ecospor and aspirin, either of the drugs. With lasers, that intake also, you don't have to think about that too much. It can be used in all patients who are medically compromised. So it is your next, the laser light is the future. And you don't have to worry that what the patient has, history has. Obviously, you have to ask the patient what history the patient has. That is obviously will be compulsory in your medical history aspect. But when it comes to your clinical aspect, that also it's easier. So these are various machines, laser machines, which are in market. There is the Soga laser numero uno, which is my personal favorite, the tabletop model, which is 450, 650 and 980. Then there is 810, which is I think most of the colleges, old colleges have it, 810 Zolar. Then there is Biolase 940, sorry. Then there is Erbium Chromium YSGG 2780. Then there is Endinium Lac. Then there is CO2, and there is erbium yak. So basically what commonly we use, or what we are considering today, is on the tabletop model, the first one. That is why I've kept it on the first. So these is just an introduction of the various laser machines, the wavelengths which are there in the market, and what we have. What makes the laser beam so powerful? And what differentiates the laser beam from that of a normal light? Like I can say that, we have lights all over the auditorium, but what makes my laser light different than the others? Because it has a razor sharp focus. So if you see this pointer is also, it's called a laser pointer, but it has a focus which is not as much as it can provide an incision. But if it's directly viewed in the eye for 0.25 seconds, more than 0.25 seconds, it will cause an irritation to my eye. So that is what is lasers. It is obviously monochromatic, it is unidirectional, and the color, what do I mean by monochromatic? There are girls in the audience, I want to know what exactly monochromatic is. Guys might not know it, I don't know. Girls, what is monochromatic, one of you? Yeah, you are giggling, you tell me. What is monochromatic? Very good. Same? No, no, you get up. I want you to get up. You have a very good face, smiling face. You have same answer? You can say out loud. Am I being monochromatic today by wearing a pink blazer and pink trouser? I am monochromatic, right? So because I do that on purpose when I'm taking laser lecture. So I can tell myself. So as you all know, you all got to know that monochromatic is having the same color. Monochrome is very in these days, so is the laser light. So monochromatic laser light, it is moving in one direction. It has razor sharp focus. You can't move this light, like I can't make this light, move around much. You can sit, it's okay. I'm not punishing you. I just found your face very happy. That is why. So this is a light which is razor sharp in focus. And this is the light which is in auditorium, which is spread across. It is not there in unidirectional. It is not there in one direction, spreading across. It is providing light to us. So that is the difference between laser light and that of normal light. And coherent means it will move in the same direction as well. It's not moving. As much as I try to move it all around the presentation, it just moves. It has one single focus. It doesn't has multiple focuses. So it will just move in one direction. That makes my laser light different from that of other lights which are available. Like you have disco laser lights, those are different. What we have clinically is different. Okay, so there are classes of lasers which I'm not covering right now because we have less time in hand. So I'll continue with the physics aspect. So today's special numbers. Who plays housies? Anybody loves playing housey in the house? Nobody likes playing housey? No? Do you all like playing housey? Yes or no? Yes. So these are special housey numbers today. It's 980, 450 and 650. All right? So these are my special numbers today. If you have these numbers, you've won the lottery because this is what I'm going to deal with the hands-on today as well. So you have to be very careful when I say I'm using 980, I'm using 450, I'm using 650. So these are my housey numbers for today. Okay. So coming to the more serious aspect of lasers. So we have something called as absorption spectrum. So what do I mean by it looks a very scary image where you have multiple dots and multiple lines. I'll make it simple. I have this USP of making everything very simple. So just concentrate on what I'm saying. These lines and points will look easier for you then. So absorption spectrum is exactly the spectrum in which the laser light is being absorbed in the medium, the chromophore medium. What do I mean by such heavy words? If this is a laser light and this is getting absorbed in, this is a laser light, it has affinity towards the pigments of my skin. For example, if the laser light is being focused on a tissue and it has melanin and it has hemoglobin, so it will be absorbed by the laser light and do the function. The affinity towards the pigments of your mucosa will be taken up by the laser light, and that is what the absorption spectrum is all about. So the diode laser, which we are going to deal with today, has more of affinity towards melanin and hemoglobin. It absorbs and it performs the function. It cannot observe. It cannot observe water. One, it cannot observe hydroxyapatite. The function of these two elements is performed by hard tissue laser. We have diode laser, soft tissue laser, so we'll have these pigments being absorbed. So this is what I mean by absorption spectrum. So today we are going to deal with hemoglobin and melanin, the soft tissue aspect. So is this image a less scary now? Yes? No reply? Yeah, good. These are the parts of diode laser. It's an optical fiber. That is how the laser energy is delivered to the tissue. Optical fiber, in an optical fiber towards the tissue. So we have coating, we have core, and we have cladding. So we have these three coatings through which it is delivered onto the tissue. These again are special numbers. You all need to pay attention to this as well, because we have three tips of, like you have endodontic tips. Yes? Yes or no? anybody is doing endo, na? So endo also has tips, or you have files in endo, right? You have 20 number file. So we have, similarly, we have tips, we have numbers. So in that, we'll have 3 numbers today, 200, 300, 400. So in Orichem laser, what we have done is, in literature we have 3, Orichem laser has 400. It is a longer one and a shorter one. So the longer one is used for more so periodontal aspect, the periodontal pocket debridement or deepithelialization or curettage and disinfection more so. And the shorter one is used for incision, the 400 one. And 200 one is used for root canal disinfection. 300 is for, obviously, in literature we have for periodontal therapy. Okay, another scary diagram for y'all. I love scaring people a little. Okay, this wavelength, electromagnetic wavelength spectrum is nothing but the colors in which the lasers are placed. So this spectrum talks about the color of the laser basically. So we have something called as UV light, which is 308. So do you all use light cure by any chance? You all use composites? Composites is started in college? Yeah? Anybody composite is started? No? Yes or no? Okay. So we have UV 308. Then we have blue light, we have red light, we have green KTP. So in blue light spectrum, we have 450, 445, 450. 450 is what we'll be looking for today. We have red light, which is 650, 660. Then there is, which is commonly available. Then we have something called as infrared, which is near infrared and far infrared. Near infrared is more so of 810, 940. Medium infrared is 2780, 2940. And far infrared is CO2 lasers, 10,600 nanometers. So this is all about the electromagnetic spectrum. So red light coming out of a laser is not necessarily red light. It is, sometimes 980 is invisible light. You have to have indicator light. So that is why 980 has that indicator light, red color light. Okay? This is what electromagnetic spectrum is. So we have beams. Next concept is beams. Why I have introduced beams in this lecture is because this is very important for us to know when I'm doing the hands-on. When there are 2 types of beams, with one is focused beam and second is defocused beam. The focused beam is supposed to be that of incision. Defocused beam is that, as sir said previously in the previous lecture, dentinal desensitization, we can use the defocused beam in dentinal hypersensitivity as well, and also for PBM as well. Okay, so defocused beam is for pain therapy, PBM, dentinal like hypersensitivity, we can desensitize the tooth with defocused beam, and with focused beam we can do the incisions. So we have to have 2 beams in laser dentistry. Okay. Next concept is laser tissue interaction. Now with laser tissue interactions, we have 4 properties of laser tissue interactions, which is nothing but reflection, absorption, transmission, and scattering. So these properties are very important when it comes to lasers. Why? Because scattering will help us not go overboard when we are doing root canal disinfection, or not go in the space where it can burn your periodontal space and fibers. And with periodontal pocket as well, we don't have to go all the way down to the pocket. Because of the property of scattering, we have to go only some mm up. We can't go completely down in a periodontal pocket with lasers. Because of the property of scattering, that is why physics in lasers is very, very important. But my time restrictions, I'll be completing only less aspect what is important for today. And when it absorbs the tissue, when the tissue is absorbing the laser, it will have interaction of absorption as well. So in absorption interaction, what happens is you have mediums of energies. Converting the laser converts into different mediums of energies: photochemical, photoacoustic, photothermal. photochemical. These are the various interactions which happen when the tissue gets absorbed in the tissues. The laser gets absorbed in the tissues. So this is what exactly happens. Okay. And transmission, when there is literally no change in the laser beam, it just like transmits. And reflection, we also have to be very careful of reflection because we can't be using many steel mouth mirrors. We have to use something called as a plastic mouth mirror. We can't use steel mouth mirrors because of the property of reflection, because it will reflect into surfaces which we might not want to get reflected into. Okay, so we have to be very careful of these properties while dealing with lasers. We just don't have to use the laser machine blindly, but we have to know the physics behind it, slight basic physics behind it, and then go with the technology. So next aspect is a very interesting aspect which is flouted right, left and center in clinical practice, and I would like to enlighten you all with laser safety. So with laser safety, you have to be very careful. As I already said, you don't have to look the laser beam directly into the eye. Once you do that, you're going to either go blind or you're going to need surgery for that. Do not look into the laser light directly. The laser beam is a very powerful beam. It can make you blind. As much good it is also bad. It has its pros and cons. So as much as the pros look very look very promising and very interesting, the cons also have to be taken care of, because every technology, like AI, ChatGPT. How many of you use AI, ChatGPT? Oh, I see hands up. Yeah. Y'all are lucky, you know. Y'all are really lucky. Y'all have ChatGPT. We used to, have this Google as our only tool, and then we used to actually, Google it and actually write our things with that. So y'all are really lucky. So as ChatGPT can or make or break your presentation, or make or break your knowledge or your exam or your viva, similarly, when it comes to lasers, it can either make or break your practice, it can either make or break your patients or your practice. Okay, so laser is like ChatGPT, very easy. You have to be careful. It has its benefits. You have to be careful with it as well. Okay. You have to maintain a distance of nominal ocular distance hazard of minimum 6 feet. Means if I'm standing here and sir is sitting there, so we have a good distance. I think more than 6 feet, na sir? Yeah. So we have like more than 6 feet of distance between ourselves. So a distance has to be maintained. You can't be wearing loops and, I'm wearing loops and I'm doing laser dentistry. That's not possible. A lot of students, my students back in Mumbai, they tell me, doc, but I use only loops and I work. But my question to you all is, like, you don't have to use the laser to that much limit. Means if you know how to use the laser properly, you will not use the laser for that long. It is a quick technology. If you use it the right way, you should just know how to use it. So it's a very quick technology one, but if you're insisting, no, I cannot work without loops, I have to wear loops and work, what can I do, doc? So we have Calzius people also who manufacture loops which are like having laser protection embedded in that loops. That doesn't get manufactured over here, that gets manufactured in the USA. One. And second, you can do double combination like the famous Indian Jugaad. You can just wear your glare over your loops and then finally work. Combine the two and work, if that works for you. I don't personally use loops and I work with laser. I use it without the loops. Other dentistry, obviously loops is a big 100% yes. So you have to be very careful. Make the assistant wear loops, the laser glares, you yourself and the patient as well. All three of you have to be careful. And the fourth person has to be either at a 6 feet of distance or has to be maybe, it's like he or she also can wear loops and then look at the procedure of the fourth glares. So normally there are 3 glares available. So we will wear 3 glares. And please don't confuse the light, the ones which are there with UV, those whitening zoom units, those orange color cute ones. We don't have that. So we have something which is optical density more than 4 should be present, protection more than 4, because the light, the laser light has to be first absorbed by that barrier of the glare, laser glare, and then go into your eye, the harmful bit of it at least. Okay. So very, very careful, and please be careful. Even if you're using a microscope, don't do it without the laser glare. It is a big no-no. because I have seen cases where they are, demonstrating on YouTube. Like I have been shown that, ma'am, look now, there's microscope and see the dentist is doing. I said, no, listen, you're going to damage the assistant's eye, the dentist's eye, and the patient's eye. So eyes are precious. Eyes cannot be manufactured. Lasers can be manufactured again, but please protect your eyes first and then use lasers. Okay. So initiate the tip before incision. What do I mean by that? How many of you, I think you all are mostly more than 18 years old. How many of you drive cars in this hall? You drive. You are above 18, I know that. Any of the students who are above 18 and they drive cars, even they are not above 18 and they drive cars? Yeah, all smiles. Yeah, oh, you are one very happy person, both of you. Very nice, I like it. You all have been good. Okay, so see, when you are driving, you have to start the car. Without that, your car will not start. Actually, now it is push press, the fancy. When I started driving, there was no back mirror. There was no camera, the rear camera was absent, and there was no we had to switch on the car with keys and take the car back and then move it ahead. We were in internship that time and I got my car, I was very happy that time. So similarly, with lasers, you have to start the laser, you have to switch it on with the help of initiation and then ultimately use the laser. Without that, you will not be able to use your lasers. It is not going to incise only. Some of them even have that doubts. Like, ma'am, laser se to incision doesn't happen only. It's just so hard to use. It doesn't cut only. Ma'am, I don't know what I'm doing wrong. Maybe you're not initiating the tip only. So initiate the tip. We normally use wine cork or we use articulating paper. Since I'm a teetotaler, I think when I called up, the Kolkata team, I told I'm a vegetarian, I'm a teetotaler. They were laughing on me on that. So I'm a teetotaler, so I don't have wine corks in my house, or I don't have wine corks in the clinic. We have articulating papers. You all can use wine cork as well for initiating the laser tips. Initiate the tip and then only use for incising. Do not use the incisions without initiating the tip. You have to start your car. Similarly, just think of your car when you think of your laser. Any which way, it costs like a car only. So think of it as your car, be it whatever, car. So just think of it as a car. Start the laser by initiating the laser and then do all your incisions, ablate accordingly. Very, very important aspect. Okay, the main protocol is you have to always suction, always have an assistant along. You cannot do laser dentistry without. If your assistant is gone for a vacation, he or she is chilling around, please don't call the patient that day. You have to suction it, power suction it, because the plumes are very harmful. Means when I do the hands-on, you will understand what do I mean by plumes. So there is a lot of smoke which is generated when you do incision with lasers. That smoke is called plumes. So that plumes have to be suctioned because they contain a lot of harmful chemicals like aldehydes and benzene rings, and even the tissue which is bacteria, virus. You don't have to inhale it. Wear a double mask. One of you is wearing a mask in the audience. You are wearing it. So wear one more mask when we do. So it's like you are safe then, right? Yeah. So double masking, if advisable, if you're feeling very claustrophobic, because a lot of people have told me, ma'am, we feel very claustrophobic when we're wearing glares and we are wearing only a single mask. It's okay, but wear a mask. Double mask is more advisable. Make sure the plumes are sucked out of the place. You have a good airy area so that the remaining plumes go out. One. Second, you have to be careful with the glare part, plastic instruments, and always initiate the tip. This is what the slide is all about. So she's looking very nice and cute, but these are not actual laser glares, but I have just put this picture on purpose because, whatever looks good, it catches attention. So she is wearing a laser glare. Okay, so she's just posing. See, the advantages of wearing laser glare is more than security. I really feel so. One, you are getting protected from the laser light. Two, if you come decked up with that mask, a head cap, the surgical gown, and you're wearing glares, the patient will feel like you're actually doing something which is not ordinary. you will actually feel, the patient will feel that you are actually investing in them and upgrading your knowledge. So it is more than just safety, it's actually stylish. It's actually a part of grooming. So it's grooming you as well indirectly, and it's also like, it's helping in a way, promoting you as a dentist who's just not into RCTs, implants and extractions. Okay. So this is why more so all the right reasons for wearing a laser goggle. And make sure the laser tip is cleaned every time you do an incision. A small tissue gets deposited at the tip of the laser tip. So that tissue has to be cleaned with a wet saline gauze. Do not clean the tissue with a spirit. Because if you clean with spirit, you do the same incision, the spirit is actually, it can cause a fire in your clinic. Do not use spirit directly into the laser beam or when you're using the laser machine in general. That can actually, one, it can damage the tissue. Second, it will blow your clinic up, you up, and the patient up. So, okay. So it's quite inflammable. So be careful with that as well. Next is this, what can happen if whatever I have said, all that, and you act like a complete rebel and don't follow my instructions and you don't follow the laser protocol. This is what can happen. Nothing more. You can have ocular damage, you can have surgery, you'll have damage to your eyes, you can be blind, one. There'll be tissue damage, the patient also is affected. So it's like the tissue will be black, charred, the ones which we see with electrocautery, black, charred tissues. So that will happen if you don't listen to the instructions of safety protocol. Then respiratory hazards, you can develop respiratory disorders, and obviously electric hazards, which is also because if you are using spirit instead of the normal cold saline. Cold saline is better in lasers than the warm saline. Obviously warm saline you use it in your RCT, but the cold saline normally we use it with implants, and also with laser dentistry we use cold saline if it's available, but do not use warm saline. It will, obviously I will not go in physics aspect of it. I'll keep it simple for you all. Don't use the warm saline, use cold saline or room temperature saline. Okay, another pretty girl. So this is like the one thing which I follow a lot, because I do a lot of cosmetic dentistry as well, a lot of veneers, a lot of composites along with lasers, because that helps me with my practice. So numero uno, I use it in my cosmetic dentistry. Then secondary, I use it in my periodontal cases, curettage, aphthous also healing, all that. So in cosmetic dentistry, there is various aspects, various procedure which we can do with lasers. And obviously this will also not just help the patient, but also also increase your revenue. So one is teeth whitening, which is my personal favorite. I love doing teeth whitening. Then there's gingival depigmentation, which you can do with lasers without having much of worrying about the bleeding aspect and the healing aspect. Then there is zenith corrections. You can do the zenith correction with laser without waiting much. There is almost no downtime. You can immediately go with the restoration once the zenith correction is done. If there is obviously restoration to be done on the same day and the patient doesn't have the time, because these days patients have lesser time in hand. Then there is lip depigmentation as well. Similar to that of gingival depigmentation, there's something called as lip depigmentation as well for patients who have very dark lips. So in that case, there is lip depigmentation. Okay, so these are the various clinical aspects of lasers, what you can apply with laser dentistry. It's not just for incising anymore, it's just not for doing frenectomies. Obviously that's the gold standard, frenectomy and doing tongue ties and everything, but more so we have gingivectomy, we have gingioplasty, we have non-osseous crown lengthening. Osseous crown lengthening is possible with hard tissue lasers without flapless one, and this is non-osseous with the diode lasers. There is what else? There is laser bacterial reduction, there's curettage, it can be used for periimplantitis protocol, which we call as LAPIP protocol. Okay, so that protocol, laser assisted periimplantitis protocol, is also can be used with laser, diode laser, so that after infection, like periimplantitis infection, it helps in reducing the risk, the bacterial count. Okay. And that is really helpful these days because a lot of patients are developing peri-implantitis. There's photobiomodulation, as I had already suggested in the defocus beam, and there is low-level laser therapy for faster healing, and there's TMJ therapy. Biopsy can also be performed, removal of mucocele, vestibulosplasty, hemostasis, orthodontic exposure of unruptured teeth, abscess ulcers, OSMF, oral lichen planus, cold laser therapy. By the way, what is cold laser therapy? Any one of you? No? You did not catch the term cold laser therapy by any chance? Any guesses? No? Okay, so cold laser therapy, we also tell like, it's cold lasers and all that stuff in photobiomodulation. So that is what I mean by that. I just had to put it. Okay, so this I get a lot from the clinicians who have already bought electrocautery in their practice, and they end up calling me for my course that, doc, but we have electrocautery, why should we come for your laser course? Like, tell me one reason why I should buy your laser. I said, listen, you should come for my course, that's definitely there, but why not electrocautery and why lasers? It's like a lot of oral surgeon also which I have trained, like one of the oral surgeons had electrocautery in her practice. And then finally when I told her lasers is really good, you come, I'll teach you why exactly lasers. Now she's practicing with lasers. She stopped using electrocautery. That is the magic of lasers. The differentiating slide will be there ahead. So electrocautery versus laser. Okay. So there is charring, which I had mentioned previously. There's carbonization, and it is more than obviously 200. I mean, as a patient, would you like these type of margins in your patients or yourself? Like if you were a patient, put yourself in patient's shoe and imagine yourself. Would you like such margins? Black charred margins in your own teeth. Will you like it? When you're, gingiva, will you like it? Yes or no? I want a big, yeah, so exactly. So if you don't want such margins in your practice, you definitely need to go for laser. Can you see how beautiful the margins are looking after we've done the incision after ablating, right? So you would want the second diagram in your own case if you were a patient and you needed zenith correction or you needed like a gingivectomy or a non-osseous CLP, you would probably do that, right? And electrocautery cannot be used for implants. It is not a hemostatic in nature. It cannot be used for pain therapy like we use lasers like TMJ, photobiomodulation. We really don't get to use that in electrocautery. We can use all of that in laser dentistry. We cannot reduce the bacterial count. Bacterial count reduction is not possible that of electrocautery. Electrocautery has limited functions. We cannot do an aesthetic gingival depigmentation with electrocautery. It will be all black in color. We rather use a burr or just incise and just open the flap and do it. But with electrocautery and laser, this is the difference. And also, it's like electrocautery may be cheaper, but in the long run, laser will provide you more patients than that of electrocautery. So why do I say what is because see, I love cars for that matter, and I used car as an example. Your electrocautery is your Maruti 800. Electrocautery is Maruti 800. Which? Tell me one car name. Kia, Syros. There's a showroom as well. Kia is there. Kia Syros is there. MG Hector is there. Like if you go for that segment of cars. But if you go for like electrocautery, that's Maruti 800. That's bygone. You cannot treat sensitivity as well. But lasers, MG Hector, Kia Syros is your laser. Okay, so with lasers, we absolutely can, live up to it. And electrocautery, we don't even have to wear that glare. So as I said, presentation matters in today's practice. Grooming matters in today's practice. So That is why lasers are not electrocautery. You don't have to think a lot, just buy the laser. Electrocautery is just for single function. It cannot perform all your function, and it might, obviously, I don't know why they're still producing electrocautery. Okay, so these are the basic product advantages and applications before we go on to the clinical cases. So we have some of my clinical cases which I would like to share, but before that we will see the product features of Soga lasers. So this is one. This is the pen type model iSoga laser 2. In this we have 980 wavelength. We have various modes and this is 0.1 to 5 watts only. As I said, it's a cute mini version for the one which are just beginning their laser practice. So pen type model is a very convenient, handy, and for those who are like striving for having more space in their practice, like they have no space in their practice, Mumbai has this problem for that matter. So a pen type model works fine, and the budget is also lesser than 2 lakh. So you can buy this laser machine and use it in for all your practices. It's a cute model, I like it. And this is your Soga eye laser. Now all of these, the advantage of both these lasers is it's handheld. You don't need a pedal. Like normally all the laser machines in the market have a pedal. So in this Soga lasers we have handheld. So we have to press the button, and then you can just like do your incision or do your photobiomodulation and do whatever you have to do with the help of the laser tip itself, right? Like we just hold it and just press it and just do whatever you have to. So this is my personal favorite. I love the tabletop model because it's very convenient. It functions very nicely. It has 3 wavelengths. It has 450, 650 and 980, which I find it very nice because the more the better. And you can perform more functions. You can perform longer procedures with more comfort with the tabletop model. These are the product features which you can go through. It is up to 8 watts. Now the next is the clinical slides, which I would like to focus on. I think this is the next few slides are going to be the most interesting slides. Moment of truth. Anybody here fan of this series? No? No? Okay. No? No? Okay. I'll tell you later. So he was a scientist basically in the series. So he was like discovering something. So it's like moment of truth. So okay. Role of lasers in cosmetic dentistry. I'm coming to the clinical aspect now. More so the video aspect. This is how the patient presented. Look at the gum. One, the phenotype was really thick of the gum, of the gingiva. Second, the pigmentation was really intense. He had good pigmentation. And the patient secretly did not know that I actually know that he smokes. He told, no, I don't smoke. I am a very nice patient. I don't smoke. And he was with his father. So I know he's a smoker. Because you know the phenotype you can actually feel. And you can tell this patient is lying to you. This patient is actually lying to me that I'm not a smoker. The phenotype says it all. And yeah, I can see his oral hygiene is also not that great. Like in general, this is a cleaned version of his teeth. Like I've done his scaling and then it has been posted. So it is a lot more redder because he had pockets, definitely. Phenotype was not that great. Oral hygiene was not that great. So the periodontal condition was not that great. So that is why there's so much of red bleeding is there, right? But not that much as compared to that of a blade. In blade, he would have bled like crazy then. So still there is some bleeding. This is how the laser tip looks like when it's placed on the tissue. So I would like to play a video of Orichem Soga lasers. So I have done this case. I think I'll just increase the sound and put the mic. So that was how the presentation was, like the video was. So did you all notice things which I have said in the laser safety protocol? Did you all notice all that? I was suctioning, my assistant was suctioning throughout while somebody else was making the video for me. Suction is very important. I was cleaning the area constantly with a wet gauze, wet saline gauze, right? And my tip was also being cleaned. I did not let it deposit. The tissue coagulum wasn't present on the tip for way too long. Otherwise, it would always cause an internal reflection in your machine, and it will obviously damage your machine. And also tissue, there will be hot tip effect and damage the tissue as well. So be very careful of the small things. It will make you a better practitioner. So this was gingival depigmentation with the help of Soga Orichem laser 980 wavelength. We can also do the same with 450 with slightly contact mode. With this, we have to be completely in contact, while 450 is more faster because it's less contact. I just wanted to show this demo because this is just for basic, like if you're just starting off with lasers. So 980 is more ideal for you, but as you progress, like you'll do 1-2 cases of gingival depigmentation, you can go up to 450 also. Because 450 is more sharper as a wavelength, it is more precise, and it is faster and less contact. You need very less contact or contactless, and you can remove the pigment very effortlessly with 450. This is my 3-day follow-up and my 10-day follow-up. As you can see, beautiful pink gums. Patient was happy, I was happy. The patient was really happy with that. So nobody asked me this question over here. Can you see this white surface? Nobody asked me why. Anybody wants to ask me why? Then only I'll answer. No? Nobody wants to know? Okay. So this is my follow-up before and after. So that was a sped up video. It's not how we do a gingival depigmentation with laser. A lot of people, they just, I've seen, they just do a brush stroke and they just keep doing it very fast and expect the laser to work. No, laser energy has to be deposited on the tissue surface to help it actually grab the pigment and then do its function. It is not electrocautery, it is not blade. It is a beam of light. Means it is a laser, it is an energy, it is a light energy. You need to respect the light energy with the tissue, with respect to tissue, and it will give you the function what you will want. The result will be there. The slower you are in laser dentistry, the faster you will be. So in life also, it's like a lot of people, they do shortcuts and then they rise up very fast. Have you all heard the story of rabbit and what was that story? Yeah, louder. You tell me. Rabbit and? You only. Tortoise. So who wins the race? So laser is our tortoise. The slower you will go. Sit. I'm not punishing you. It's okay. I'm just like, I'm just liking people to, get up and talk. It's okay. So that you all are awake. Okay. So like a tortoise, it will go slow. It is steady and slow. You go slow and steady with laser. It will reward you back. You will win the race. Okay. So this was my actual moment. I was doing it nicely and cutely. It's like meditation. Whenever I have to do a laser case, I feel I am doing a meditation. Because it has to be slow, because it's delicate. The tips are also delicate, otherwise you will end up fracturing the tips. The most difficult students to teach are oral surgeons. Any oral surgeons over here? No? No, they are the most difficult students to teach because they have a habit of cutting through with blades and everything. So it's the most difficult to teach them. Otherwise it's all good. Oral surgeons are the most toughest students to teach. So it's very slow and cute, and it's like meditation, like yoga. Just be nice and slow, you'll be just fine. So this is one more case of laser depigmentation. You can see in this slide, this is half pigmented and half like laser technology. Laced with laser. This is how it looks like during. And photobiomodulation post depigmentation. So photobiomodulation is nothing but your low level laser, PBM, or cold laser therapy. So this is photobiomodulation post depigmentation. So you have to do this every time you do a depigmentation. Why? Because this will provide complete benefit of the laser machine that you have bought. Okay, so just doing depigmentation and running away will not help. Doing a photomodulation, which takes only a minute or so, just do that and see, you will come and thank me later. Okay, this is my 3-day follow-up, which is pretty impressive. And this patient was genuinely a non-smoker. His phenotype is not that thick, it is medium. So I could guess from the way he was actually honest about this habit of not smoking. Okay, non-osseous crown lengthening. You have a zenith of 1-1, which is uneven. 2-1 is at a higher zenith. This was an aesthetic case. You can see some amount of brownish lesions. You can see some brownish lesions. That's because of the old PFM crown she had for many, many, many years. And finally, then the crown was out. So this is how the tooth was looking like. So this is the during. Equal gingival zeniths are achieved. This is with 980 wavelength. And this is immediate post-op. This is not like, I have not given the post-op for 3 days later or 5 days later. This is what I want to tell you all, how good lasers is. It doesn't cause blackish margins. It's amazing. The healing is amazing. It's bloodless. It's painless. Why would I not use lasers? Why would I use Maruti 800 when I can use MG Hector? So this is what my prosthesis looked like once it was completed. She was very happy, and it was zirconia crowns, obviously. I personally don't put PFM in the anterior zone as much as possible, but can't really help if patient insists on putting PFM. But I personally advise the patient, do not go for PFM because it causes tattooing like this. Okay, this is one of the cases. This is done, okay, this guy is a TV actor. I can't take his name, so I have done this case for him. So he was starting a new serial, and he's like, look, Nami, I don't have much time, and we need to do something about my smile, and I don't want to put aligners. Ideally, the case was for aligners. I don't want to put aligners. I don't have the time, and I need to go for my look test in this amount of time. I said, okay, challenge accepted. So if you can see his gingiva, in his marginal gingiva, you can see the free gingiva, you can see the attached gingiva, you can see some things, right? You can see some erosion kind of a thing. That's as if I have scraped the margin. That's the gingival depigmentation which we did for him. That was almost immediate. I don't have the previous pigmented stuff because we just had to start the case very ASAP. And then I did zenith corrections with respect to 1, 2, 2, 1, 1, 2, 1 and 2, 2. This is multiple zenith corrections at the same sitting. After depigmentation, I advise doing the gingival zenith correction. That is more advisable than doing the gingival zenith correction before and then doing the depigmentation. It will make your work much more easier if you do depigmentation first and then do the zenith correction. And this is my case. I have done veneers for him in 6 of his teeth. And he's very happy. This actor is on Star Plus right now, doing very nice in Prime slot. And I'm happy that my smile is flashing on Star Plus now. Okay, this is another glamorous part of laser dentistry, laser teeth whitening, which is my personal favorite. And I love doing whitening. This is a small video. I personally love. I think they should make me brand ambassador for that also because I love using that face. Every conference I will tell. Every conference every lecture I tell that I love using Polar Office. I just hope somebody tells them how much I promote them without even being paid. So this is a Polar Office paste. Yeah, you also use it? Okay. Yeah, please tell them. So this is a polar office application tip bleaching agent. It is more ideal for 450 wavelength. I do whitening with 450 wavelength. As I told, Housey numbers 980, 450 and 650 are the special numbers for today. So I'm using 450 as my wavelength for teeth whitening. Okay, it is a non-ablative procedure. That means there is no incision. That means defocused beam is to be used. So the next one. After application, I'll be doing the application of the laser light Soga Oricum laser. This is using the whitening handpiece. It is a multi-purpose handpiece which I'll be coming across in the next few slides. Look how happy the patient is. She was very happy. So she was very honest as a patient. She told, look doc, I smoke. I have horrible yellow teeth. My daughter keeps telling me that I need to get a teeth whitening done. So finally, it's like when she had white teeth, look at the brightness of her smile. And look at the cheer in her eyes. That is what cosmetic laser dentistry does to patients, my patients. This was for a friend who was getting married the next day, and she came up to my clinic and I had to do her teeth whitening. So crazy good. This is a bridal teeth whitening which I did for my friend. So this is Coca-Cola stains, which I think in college you must be having a lot of them. In private practice, I was like, oh, it reminds me of college. So since I've come to college, this is like a Coca-Cola stains, and a lot of stains were there in the lower aspect and the upper aspects. As you can see, there's a lot of bleeding in the marginal gingiva as well, in cervical areas as well. Yes, the patient was not really fit for doing the whitening on the same day, but he had, as a clinician, you have to compromise sometimes, but never in such a case you have to do the teeth whitening on the same day. If you have to, place the gingival barrier really thick of what you actually place, and then do the teeth whitening to protect your gingival tissues, and then do the whitening. This is a whitening handpiece. It is multi-purpose in use. So basically, it is not just for whitening. In Oricum Soga literature, they have not really published this, but I'm telling you as a clinician and as a user of the Oricum Soga laser that this is a multi-purpose handpiece. So teeth whitening definitely yes. It can be used for TMJ therapy as well. TMJ therapy can be used, this same handpiece. And third, they can use for photobiomodulation as well. For example, if you're doing a gingival depigmentation. So you can use this directly on this upper arch and lower arch, and then accordingly you can do the photobiomodulation. Now endodontics. I think this topic is very close to most of the clinicians. Whenever I start this slide, they all become very attentive because endo is bread and butter of dentistry. The applications, it's like I have always asked that, doc, only disinfection, but I would ask how many retreatment cases are you all getting these days, right? Many of them, because the disinfection is incomplete with EDTA and even with sodium hypochlorite, whatever techniques you are using, it's still incomplete. There's always a chance that you might not have disinfected the deeper E. coli. They might be sitting in dentinal tubules, you might not even know that it's there. Like, it's a blind procedure. You can't take a microscope along and see in the canal, right? So that is why laser disinfection plays a very important role, because it is 100%, 99% to 100% in literature. It's been proven that with laser disinfection, the chances of retreatment decreases substantially. There's almost no chance of retreatment. And the disinfection is absolutely clean and the canal is good to use. But be very careful of using a saline, draining this, like doing a BMP and then irrigating with a saline. Obviously you can do whatever saline you want, but it should be wet with saline, or hypochlorite, that's not a problem, but it should be wet. The medium should be wet, and then the disinfection should be done with lasers. So this is my second slide of the laser disinfection with the root canal disinfection with lasers. So basically you have a methylene blue dye or toluidine blue dye which you inject inside and then you do the disinfection, the affinity of the dye, the interaction of the dye with that of lasers will make it more powerful of a disinfection than if you do it without the dye. So it is nothing called as APDT. APDT is antimicrobial periodontal therapy. It is like APDT, right? So APDT protocol has to be followed, diode lasers. So this is the article which supports my claims. Okay, so this is the article, antimicrobial photodynamic therapy. So this is the protocol. You can have a read, you can have a picture and just read it later, how it goes about and what exactly happens inside the canal when we actually use a dye. That's just a vague term that we use a dye and the laser absorbs more quickly and does the infection more efficiently. But the mechanism of action is like about the singlet oxygen making formation and all that. I'm not going in detail because we have less time. Next is, I think this is like less known aspects of laser dentistry, or more I can say known, but people don't really know how to use it. Like people are knowing, it's not that the people don't know anymore, people know a lot of these aspects, but obviously I would like to put a light on these aspects. TMJ. So TMJ pain is more common in after COVID, especially after COVID. Can you all tell me why is this happening? TMJ issues have risen all, like, you know, as future clinicians, you all should know that TMJ issues have increased more so after COVID. Can anybody tell me? I can hear some. Can you all tell me? One of you all, raise your hand and please tell me, if possible, what has happened after COVID? Life has become uncertain, right? We are scared that I don't know who will go when. So, and more so if you all follow economics of the country or worldwide economics, it's in a bad state. Like we as dentists are still good. We are not in corporate, it's actually good because most of my patients who are having TMJ problems are either corporates or they are like into fields which are directly related with economy. We are also related with economy, but in our aspect, we are not really related directly, we are indirectly related to economy. So we are still blessed to be dentists. And so basically the stress levels have skyrocketed after COVID. There's uncertainty of life. When you are uncertain that what will happen, like even if you have a slight cold and cough, you become anxious after COVID. Patients do become anxious. The healing has slowed down. We have to give more medicines to heal in general. And because obviously the stress levels are so high, the immunity is down, right? So with TMJ, it's high in demand, and also the very important, this is all the overall view. But the insight of why TMJ therapy is in demand after COVID is because of the numero uno reason of clenching. The patients have bruxism, daytime, nighttime, they have left, right and center. At least in my clinic, I deal with at least 2 to 3 cases of bruxism every single week. I have at least one. 2 to 3 were very common when COVID had just ended. We had just, you know, I had just come with laser technology in the clinic and it was very high when the unlock and everything was on, and, you know, we still had those, you know, breakdowns and all that stuff. We still have lockdowns in some times. That time it was more high. It is becoming lesser, but it is high. Even, I mean, the youngest patient I've seen is like of 18-year-old student who was like in stress. I said, listen, what stress do you have? Like, listen, I'm stressed. I don't know why so much of stress is happening among students, but even 18-year-olds are getting affected by bruxism. Back when I was 18, I didn't know what stress is. So this is why it's changing. Lifestyle changes is bringing about TMJ. Because you're clenching, your muscles are constantly in action. You're constantly putting the muscles together. There's no rest for your masticatory muscles. That is why there's constant headache towards the temporalis muscle, towards your head. And the patient complains, doc, I have pain here. I have pain in my entire jaw. I'm not able to eat. So when I check intraorally, there's literally nothing. There's no cavity. I do an like normal protocol, you know, we've been taught in college. Like I'm telling college aspect. Or, you know, your patient will say, ma'am, I have a pain here. Ma'am, idhar dukh raha hai. Sir, idhar dukh raha hai. What will you do? You will take an IOPA, right? You will take an IOPA, and then you will determine the diagnosis. What exactly is the cause? You see nothing, you go rushing back to your teacher that there's nothing. There might be sensitivity, okay, theek hai, that also you sort. There might be like trauma from occlusion, from adjacent restorations, you might solve that also. But what after that also the patient doesn't heal. Even after, I'm not saying trauma from occlusion isn't a part of TMJ therapy. We do relieve occlusion sometimes, and that's also it can be one of the causative agents. But with TMJ, it's like the muscles, when you're clenching, they are constantly under masticatory load. So that is one reason a lot of clinicians will prescribe a muscle relaxant. You take muscle relaxant, you'll be fine. But tell me that how much drowsy the patient feels after the patient has taken muscle relaxant, and can the patient who might be on a night duty or maybe having shorter sleeping hours will feel sleepy throughout the day. More so gastrointestinal issues. Guts are becoming more sensitive these days. We are a very sensitive, like we are becoming sensitive over a period of time. So the medication might not suit some of the patients, okay? Muscle relaxants might not suit. So that is why without any painkiller, without any muscle relaxant, we do TMJ therapy. TMJ therapy with the help of laser. We do the therapy in all the masticatory, okay. So what are the masticatory muscles? I want the audience to tell. Yes, tell me. Very good. So these are the muscles, and you have to target those muscles intraorally, extraorally as well. Intraorally towards the, what was the muscle? It's okay. Intraorally, I will show you in the hands-on thing. So intraorally and extraorally, you have to deal with the light, laser light, and you have to show the laser light in those muscles. So in your masticatory muscles, you have to show the laser light, you have to expose the muscles, you have to expose the tissues with the laser light, with the handpiece. And then you will have good results without any popping any painkiller or any, like as I said, it's the AI, new AI of dentistry, lasers. So it's actually good on the stomach, patient is happy, and it gives instant relief. While muscle relaxants take some time to completely relieve, while this, within 6 sessions, the patient, sometimes even lesser than 6 sessions, within 1-2 sessions, the patient is fine. Sometimes if it's severe, it can take up to 6 sessions for it to resolve. Okay, now this is one very interesting slide, oral lichen planus. Okay, so oral lichen planus, OLP, the patient was diabetic since very long. Patient was on insulin for very, very, very long. As you can see, its Wickham striae presence is there, and obviously systemic condition presence is there. So I did, this patient couldn't even have water when I first saw this patient, and it was really an emergency. He's like, look doc, I'm not even able to have water, forget about food. I am starving. I'm literally starving. I don't know what to do. The cousin of his, he had a nephew. So he asked his nephew, he gave him some test gel. No, test is common now for us. We all love tests, right? We all love test gel, yes. So a test was prescribed, and he still did not have any relief. So he came up to me, doc, what should I do? I said, listen, sit. I will do a laser PBM. And the next question for patients is, doc, kuch side effect to nahi hoga? This is the next question which always is there. Do we have any side effects? I said the only side effect will be, you will be absolutely fine and you will thank me later. So I continued with his PBM, like the photobiomodulation therapy, laser therapy, which we do with the handpiece. This is apparently TMJ handpiece in SOGA literature. I call it the PBM handpiece. So PBM handpiece for 980 wavelength. I have exposed the lesion to it. This is the 5th day follow-up. Yeah, I'm not kidding. Yeah. Of course, I had started some multivitamins also for him, but this is the 5th day follow-up. No fancy medicines, no surface application. Test, I said, if you want to apply, you apply. If you don't want to apply, don't apply. 5th day. And I couldn't get the 10th day follow-up because he was just fine. He's like, doc, I'm fine. Chalega, beta, bahut dua hai. Continue with your work. I want you for follow-up. So he did not come for the follow-up. Otherwise, we would have a 10-day follow-up. So he's doing fine. And this was my case, which I call my personal favorite. And he bought me this big bag of perfume after that. Like I have an entire stock of perfume for my entire year. See, this is why I call laser dentistry very rewarding and the future of dentistry. Okay, next is laser biopsy. So laser biopsy is very, like, in these days, of course, with electrocautery you will char the tissues. But if you know how to use a laser correctly, you will not char the tissues, and you can take the adjoining tissues also. Like if you use a blade, you have to half of the time control the bleeding, cut, control the bleeding, cut. Adjoining tissue also you have to, just tap, tap, tap and see and then cut. You have to cut, 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 cut. But in case of laser, there is no such issue. Like there is hardly any blood. The field is so clear, you get to know what you're doing. Be it extraction, okay, I will say be it extraction, be it surgical site, you have to see what you're doing. You cannot see what you're doing when it comes to a blade, right? But if you're doing with a blade, it's like you just keep tapping and there's waste of time. Half of the time you're controlling the bleeding. So with laser, that aspect is also taken care of. I did a laser biopsy. So she had this boil. I will come to that. I want you to guess what exactly is this boil on the tongue. She had this irritation from the last few years, and it became into a big stuff like that, and she was not able to swallow. She's not able to bite. She's like, I have problems in biting. I'm not able to swallow right. I said, okay, let's do a laser biopsy to see if everything is all right. So I took an incision, I did a laser incision, see how clear my margins are. Can you all see? I have taken the adjoining tissue as well with lasers, and this is what the tissue looked like after excision. So what was my result after biopsy? I want you all to just guess. Yes, please tell me. Perfect. 100 on 100. Irritational fibroma was the answer. So that is how irritational fibroma was also treated. Immediate post-op, you see there is no bleeding. I have not done any fancy work. I have just done incision, my excision with the laser machine, with the laser tip. And I have done photomyomodulation, and the bleeding was not there at all. And she is also having multiple systemic issues. She's a diabetic. Still there is no bleeding. This is my follow-up 3 days later. This is my follow-up 7 days later. The coagulation, protein coagulation has started. White structure is a protein coagulation which has started. It will continue to do so, and she's healing. She's doing just fine. Okay, this tumor is normally, it's like, if you would not know, this is someone who was pregnant. She was in her seventh month, and this tumor was there, and she was scared. She's like, listen, I'm not dying, right? Like, listen, you're not dying. This is not cancer. Because you're pregnant, your hormones are acting up, one. Second, you are not having a good oral hygiene, not at all. So this is what pregnancy tumor looks like. After 3rd trimester of pregnancy, you see a pregnancy tumor coming up, also known as granuloma gravidarum for that matter, the official name. So post-op healing, 3 days. If you can see, I've also done a laser curettage. So what did my protocol was first SRP, scaling, root planing, 1. Second, after scaling, root planing, there was immense bleeding. It had to happen. But third, I did a laser curettage. I did deepithelialization, inner pocket deepithelialization, outer pocket deepithelialization. Outer pocket I had to obviously excise the tumor off, right? So there was all these protocols which I followed, and this is my follow-up, healing follow-up 3 days later. And this is my 7-day follow-up. Pretty much good. Patient was happy. I was happy. The gingiva, the attachment of the gingiva was also great, because there was loss of attachment in the gingiva. Obviously, we had to do a curettage, and now it's much more tighter. She's happy. She's been blessed with a baby now. She's happy. I'm happy. But it's like it can scare the patient. And for your knowledge also, it is only there in pregnant women. But if such an issue you see in patients, obviously you feel that something you're not sure of, you should do a biopsy. I tell everyone, if you're not sure of what the lesion is, do a biopsy. Okay, this was my before, this is my after. Okay, one more guess the case. Who will guess this case? Yes, please. Okay. Yes, yes. Others should also know. Yes. Yes, yes, good, good. I can see them participate. Geographic tongue, you are also right. Geographic tongue is, it's like in normal terms, it's geographic tongue is just like you see in patients and they're not having a problem with it. In general, geographic tongue is not symptomatic in nature. In general, you see some patients have it and they don't have a problem. But if they have a problem, they have irritation, they have burning, and can easily get confused with burning mouth syndrome. But in this case, you don't really have to confuse it. Look at the history, look at the adjacent tissues, adjacent mucosa, then definitely this is not burning mouth. This patient was like after menopause, okay? So what happens is after menopause, she's old, she's diabetic, she's a 70-year-old patient, by the way. So she was having a lot of issues while having normal food and water as well. So geographic tongue, glossitis, also some of them say, this is post-op 3 days. I did nothing, I just gave laser light, the healing light, and 3 days follow-up. So this is the magic of lasers. I used 650 nanometers of wavelength. So this is 650 effect in 3 days. And she was able to at least, come back to normalcy slowly, and she was fine. After that, I did veneers for her. I cannot show veneers over here, but I would have loved to show veneers because she wanted to close her diastema after that. She's like, now I want to close my diastema. Yeah, so that's my oldest case till now. 70-year-old, I have done veneers for. I'll probably show you in the break, like after we are done. So I've done veneers for this patient after that because she was so happy with me, and she's like, you only do my veneers. This is a classic result of PBM and more so of 650 wavelength. Okay, in periodontics, the role of lasers, the OG lasers started with perio for that matter. Like we had PBM, we had other technology advancements much more later. We started with the basic incisions first with perio. So the OG, I'm using the word OG because this is a college and I want to relate with you all. So the OG, the original part was with perio, right? Yeah. Okay. So, many of you all, you must have seen the upper phreniectomies, right? So the upper arch phreniectomies, the label phreniectomies for the upper arch. I'm showing you the lower arch. So, can you see the stretch of the frenum and it's causing some amount of recession? Can you see the stretch happening? I'm not doing anything. I just retracted the lip and I saw a localized recession. So I just happened to examine the patient why exactly all of his teeth were just doing fine without recession and why one tooth was having recession. So we discovered there was a frenum pulling the gingiva down and there's a recession which is also causing him sensitivity, right? And he was feeling weird in that area. Obviously, there was trauma from occlusion as well. We relieved that as well later. So there's a diamond shaped incision which I have provided. Okay, so very cute incisions. I have seen that clinicians provide, especially because you're using lasers, you are providing starfish incision. Laser is a star, but don't make it starfish. Don't make it big. Make it as small as possible, but make sure all the attachment is relieved and all the tissues are clear. The connective tissue is completely clear. Okay. This is a small video which I'll be playing. So it's just a small incision with 980 because it was not very big for incision. We did not really need 450. Can you all see there is absence of recession almost immediately? Can you all see that? Right? The patient has flown back. He's happy, I'm happy. The patient has gone back to USA. Probably when he comes back after 2 years, I will have a follow-up. Maybe when I'm presenting in my next lecture or whenever there's a follow-up, 2-year follow-up, I'll have a 2-year follow-up for this case, right? So this is the case where the patient was unaware of him having a frenum and him causing a recession. So not all frenums have to be done frenectomy with. You can have frenums which you just leave them the way they are. For example, the premolar, the premolar area, if that's not causing recession, you can leave them the way they are, just leave them. But if it's causing diastema, it's causing like a recession, you have to go for a frenectomy and convince the patient as well. So this is what, I can tell you the recession is gone almost immediately. I have not done any graft or I have not done any fancy flaps or something. I have just done incision of the frenum and we are sorted. Now can you all notice there's a diastema, small diastema. So in that diastema you see there is there's some amount of diastema and there's a thick attachment, mucosal attachment. Okay, So next, I have done a frenectomy over here because apparently she had a history of a failed orthodontic treatment which couldn't really close her diastema. And she's like, doc, how much ever the doctor tries, it's not closing. The diastema is not closing. The space is not closing in between my teeth. I said, listen, why didn't he suggest you a frenectomy? Maybe he doesn't know how to do it. I told her. So we just did a incision, frenectomy. So I call it, I love diamonds for that matter. If you all want to gift me anything, you should give me diamonds. I love diamonds. So this is a solitaire incision, okay? And I call it solitaire incision because it resembles like a solitaire. Diamond is okay, but it's like, it resembles very neat. It's not very, the margins are cute and it resembles a solitaire. So diamond, solitaire, whatever you want to call it, I call it the solitaire incision because I don't make it very big enough to at least relieve the fiber muscle attachment. So this is my 3-day follow-up. It's completely healed. I mean, not completely healed. There is good healing. You don't get that healing with blade. And this is my post-op follow-up after 15 days. You can appreciate the diastema is already closed on its own. I have not done any efforts. The aligner treatment is still on for this patient for whatever the bite corrections are and whatever minor is. Can you all see? This is like small diastema, and after immediately frenectomy, the diastema is closed. I did not do any aligners. I just relieved the frenum. That's it. It's so simple sometimes. And this, how many of you are clinicians here and remove this area with a burr? Are you all guilty of doing that? Smile, yes. Are you all guilty of doing that when you get a class 2 or you get a prep, in your clinics? So are you all guilty of just doing it, removing that little tiny gingiva with the burr and then, finally waiting for the bleeding to stop and then telling the patient if it's bleeding too much, come tomorrow, come 2 days after, Sometimes we have to do that, not with lasers. Lasers makes life easy. I have done the incision. I have removed the excess gingiva which was present in the mesial aspect, in the mesiolingual aspect, and I have done a cleat incision and it's all gone. Immediately, restoration is also placed. So your time is saved, your gloves is saved, your patient time is saved, and these days patients want everything very fast. Like they want abhi chahiye. I want the results right now. So for that, lasers is your ChatGPT guide for your clinic. Okay, so now laser curettage. This is, I think, a very interesting concept. I think sir must be doing it a lot. Hai na, sir? Laser curettage with lasers. And I mean, you must be opening flap and only doing zada. And any which ways. So laser curettage, it's like a lot of people, we'll give mouthwash, we'll give scaling, and we'll say the patient that come after some days, and then we'll do a bridge, right? Wrong. If the probing depth is more than 3 mm, you have to check the probing depth after your cleaning. If the probing depth is more than 3 mm, do your SRP, that is root planing, do your laser curettage, inner pocket, outer pocket, and then give the patient back. With such a tooth, where there's so much of inflammation, there's no point you're gonna just leave the tooth that way. Immediate post-op, healing post-day, 4-day follow-up. I have not done any gingivectomy over here. No CLP, nothing. No CLP, no gingivectomy has been done over here. It's just plain, simple, little perio and little bit of laser curettage. So it's all perio application, SRP, laser curettage, you're sorted. Inner pocket deepithelialization, outer pocket deepithelialization. That's it. And PBM. PBM is photobiomodulation after your procedure. So that will help in healing. I have done no gingivectomy. It gives me a good height. It gives me healthy gingiva, and it gives the attachment of the gums of the gingiva is also extremely tight. Yes. Laser curettage, I'll go back to the slides. There is bleeding on probing. You have to first check. There is looseness of the gum. The patient will only tell you. There is, ma'am, my gums feel loose. And if you see the attachment loss is present and the probing depth is more than 3 mm. So 3 mm to 6 to 7 mm is your curettage, laser curettage. More than 6 to 7 mm is your LANAP protocol, which is done by ND Yak. But LAPT is normally, it is the protocol for diode lasers. So we do that after 6 mm, 7 mm, we do that. Laser, LANAP and all that. So curettage you can do very routinely. A lot of people confuse curettage with laser bacterial reduction. Laser bacterial reduction is a protocol which is done in a healthy mouth not having pockets. This is the pocket depth. Periodontal pocket depth is more than 3 mm. You don't, the patient is, nowadays the patients are systematically compromised. So you try to do a laser curettage without opening the flap. And the results are pretty promising. And also when you see the patient has slight, very slight, grade 1 mobility. Sometimes, not all mobility. Huh? Only grade 1, you see it can be salvaged. And you see there is trauma from occlusion. You have to relieve the occlusion as well. After doing curettage, it's mandatory to relieve the occlusion if it's present. Because mostly it will be. In this case, it wasn't trauma from occlusion. In this case, it was a periodontal infection itself. And the systemic condition which the patient was undergoing and poor oral hygiene. So these are the indications. More than 3 mm, you see the patient, the attachment loss is present. You see the gums are like, looseness is present. As the patient says, my gums are feeling loose. There's little shaking of the tooth, which actually is not. It is intact. But you may feel there's grade 1 and trauma from occlusion, do this. And if like sometimes you can even splint the tooth in the anterior section. After that, after reducing trauma from, relieve the occlusion, splint the tooth, done. This is one very young lady. She's hardly 20 years old. So we did that for her as well. No, she is not having, she's not pregnant, but we just did this. So if you all see, there's another recession in this area. Can you all see? What will I do after in this area? Yes, tell me. What did I show in my previous slide? Frenectomy. Label frenectomy in the lower. There was a frenum pulling it down. Later I have done that in my course. Okay, so now operculectomy. We are almost at the end of the slides. So operculectomy is done with 450 wavelength. I personally use 450 because I feel that 980 is less aggressive than 450. 450 is more aggressive than 980. This is photobiomodulation post, and you can see the follow-up results. And this is upper and lower. This is the lower one, and this is the upper one. Upper one is rare. So we did a small excision, and then we were able to do photobiomodulation, and this is the result, upper and lower both. So we did a dual case. It's normally only lower, but upper also slight. We cannot really call an operculum, but yeah, it was like an operculum only, very small. Orthodontics, we have like exposure. The canine was down, and it was covered by gingiva, thick gingiva. The phenotype was thick. And this was very beginning of my laser practice when I just started off my laser practice. So I had good 1 year of follow-up. So this is my one, like I'll just show you 1 year follow-up. This is immediately post-op. You can put the brackets immediately after your incision with laser. So you don't have to wait. So it's like it's saving your time, it's saving patient time. And you can see more patients now. Your revenue will grow if you see more patients, right? So 1 year. This is 1 year follow-up. So I had a good 1 year because that was the beginning of my laser practice, and now we are at 1 year. This is my last clinical file. So this is second stage of implants. We use like diode, okay? Diode laser, we expose it flaplessly and we place the analog and we take an impression, open tray impression, closed tray impression, water impression, or nowadays we have those guides also, and then we take digital impression. So you can just do it flaplessly, take the impression, and you don't have to give antibiotics. Like when I was not practicing laser dentistry, I have done the blunder of actually exposing it with a blade and then opening the flap and then suturing it back, putting the patient on antibiotics. So that was the blunder which I have done. You all have laser, don't do that blunder. This is how it will look like. Okay. Lastly, I would like to, if you all want to come for my course, it's happening in June. So it's the 5th batch which I'll be taking for a 2-day course. If you all are interested, any of you is interested, you all can definitely contact me for that. It's happening in June. It's a 2-day course. Second day, it's the highlight of the course is I give hands-on on patients. Like you all have to practice on patients. So live demo is definitely there. And also the participants, like my students, like if you are my student, I will let you practice on the patient. And I'll be closely seeing what you're doing, how you're doing, and handheld guidance by me. So that's a 2-day course happening in Mumbai, where I live. And I take it for 2 days. If anybody is interested, you all can please come. I'll be more than happy. This is a slight glimpse of my course. First day. It happens in a training center called as Novel Medic. The second day I take it in my clinic, Savi Dental Clinic. The students are very enthusiastic. I'm giving a live demo. Students are assisting me and they are seeing very closely. I take very limited number. If you are seeing, and this is my student practicing on the patient. I'm holding them if it's going wrong. So, and she was excellent. She was doing it all by herself. And I'm telling them what exactly they were doing right. This is one of my students giving a testimonial. It was just like organically coming in the video. This is a certification. We give certificates also. So you all can actually put it in the clinic. And you can, actually see the patients will see in the waiting hall. And they can actually, be assured that they are in good hands. Because everything today requires certification. So this is what my details of the course are. If anybody is interested, you all can contact me. Limited seats, inquiries, touchwood, with God's grace, have started again for the course. So it gets full fast, touchwood. So you all can also come if you all want to. It's a 2-day course in Mumbai. Okay. So thank you. You all were a lovely audience. I really enjoyed lecturing you all and a very happy audience. I'm so glad. Thank you so much for your time and for patience throughout my lecture. Thank you so much.
It was a fantastic presentation, Nami. It encompassed almost all the procedures you do with soft tissue lasers. And because lasers are not very new in the world, but India is getting a little slower in laser for last 10 years, but because we know that diode lasers can actually transform the practice, and it has happened to me, happened to you, and probably it will happen to everybody who has used, because Sammy was talking about cars, laser is like cars. If you don't have, you can travel by train, but once you're habituated to travel by cars, you will always require a car. Thank you for giving a nice presentation. Thank you. Appreciate it.
Students, kindly wait for 2 minutes, just 2 minutes. An announcement needs to be made. Just wait for 2 minutes.
I should do this way. I have to ask so much.
Thank you so much, Dr. Juneja, for such an outstanding and enriching and clinically oriented lecture. Thank you so much, Dr. Himadri Chakraborty, sir. In light of recent terror attacks in Pahalgam, Kashmir, I request you all to kindly rise up and observe a moment of silence for all the souls of the victim. Thank you so much. Now I would request all the registered delegates to kindly scan the QR code which is pasted near the entrance and also at the JB Pharmaceutical stall, and then you all can collect your food packets from there. Kindly fill up the feedback form and you can collect your food packets from there. And you can collect a small gift from the Oricam stall. And I request all the dignitaries and the registered delegates for the hands-on workshop to please kindly report sharp at 1:30 in the flip classroom, which is just opposite the auditorium. Please report at sharp 1:30.